Hello everyone, welcome back in this e-lecture series. Okay, so I hope you have already watched my videos on anti-tubercular drug, and now for the today's lecture our topic is anti-leprotic drugs. Okay, the drugs which are active against the leprosy. So leprosy means Kushtrog. So this is a very deadly disease, as all of you know. But in the recent years we have, because of the availability of very good drugs, the burden of disease is drastically reduced. As you can say, the prevalence is drastically reduced. Okay, so in today's lectures I am going to talk on the introduction of leprosy, then classification of various drugs used in the leprosy, out of which the three drugs which are important. So first we will talk about Dapsone, Clofazimine, Rifampin. Okay, then there are some other drugs which are used in the leprosy, so we will see that which are these drugs. Then we will go for multi-drug therapy, that is also called as a MDT, multi-drug therapy. For there are two types of leprosy, multibacillary leprosy and paucibacillary leprosy. Okay, multibacillary leprosy is a MBL and paucibacillary leprosy is PBL. So we will see what is the pharmacotherapy for these two types of the leprosy, and then we will proceed for the treatment of lepra reactions. Okay, so now yes, the introduction of leprosy. So leprosy, like tuberculosis, it is a chronic granulomatous infection. Okay, so there are the granulomas which are formed. Okay, and it is caused by the organism called Mycobacterium leprae. As you know, tuberculosis is caused by Mycobacterium tuberculosis, leprosy is caused by Mycobacterium leprae. So these are both caused by Mycobacterium. Okay, and the leprosy, it primarily affects the three organs or three parts which are skin, mucous membrane and nerves. Okay, skin, mucous membrane and nerve. So there are mostly the nodule formation in the cutaneous means skin and in the mucous membrane. Okay, and there are damage to the nerves. Okay, especially the peripheral nerves. Okay, so we will see the little bit pathogenesis later on after we cover the drugs. Now leprosy, it is more prevalent among the lowest socio-economic strata of the society, the poor people. So we can quite frequently see the patients of leprosy, those which are a beggar or those who are very poor. Okay, and they don't have access to the healthcare facility. Okay, and the another reason, then they think that this is a social stigma. So because of the social stigma, many patients exploit it for begging and do not come forward for the treatment, and this is the biggest hurdle in eradication of leprosy. Remember, we are in a phase of elimination of leprosy in India, but not totally eradicated the disease. So what is the reason we don't have a drug? No, we have a drugs, they are very efficacious, but the people are not coming forward because they want to take advantage of this. Rather than advantage, I will use the word exploit it for the begging. Okay, and because of that it bears a social stigma. But as I already told you, due to the availability of effective anti-leprotic drugs, now it is entirely curable. But the only thing which is the still a concern, that if any deformities or defects happens in the leprosy, then they may not be totally reversible. Suppose if any nerve damage occurs, suppose to the ulnar nerve or median nerve, and there are the claw hand, or there are the some ulceration of digits, so they may not be totally reversible, especially nasal deformities. All this can happen in the leprosy as a complication. Okay, now coming to the classification of the drugs. So drugs used in the leprosy, the first one is the sulfone. Okay, so sulfone is chemically similar to the sulfonamides. The mechanism of action is also similar, and the drug is a dapsone. Okay, that is also called as a DDS, diamino diphenyl sulfone. So this is the first drug in the leprosy, Dapsone. The second drug is phenazine derivative, and the drug is Clofazimine. Okay, the drug is Clofazimine. Remember, the phenazine derivative, it is that chemical group or genus. Okay, so you may tend to it may not be necessary to remember this, but the drug name you should remember. The drug name is Clofazimine. Okay. The third one are the anti-tubercular drugs. So as the name suggests, these are the actually useful in tuberculosis, but apart from the tuberculosis, they are also useful in leprosy. And the drug is Rifampin or Rifampicin, and the second drug is the Ethionamide. Okay. Then the fourth group of the drugs, which are the other antibiotic. Okay, so here there are mainly three classes of antibiotics which are useful apart from rifampicin. Sorry. First one is the fluoroquinolones, in which Ofloxacin, moxifloxacin, and some other like pefloxacin and sparfloxacin have anti-leprotic activity against Mycobacterium leprae. Then the second group is a tetracycline, out of which a drug useful is Minocycline. Okay, and third group is a macrolide, out of which the drug useful is Clarithromycin. So Ofloxacin, moxifloxacin, Minocycline, Clarithromycin. These are the other drugs which are especially a reserve drug. If there is a resistance to the first three drugs, then these drugs are mostly used or come into the play. So this is all about the classification of drugs. Now we'll see the first drug, that is a Dapsone. So Dapsone is the DDS, means diamino diphenyl sulfone. So you can see there are the two benzene ring, and there is a two amino groups is as per the chemical structure, and they are bonded by SO2. So this is the simplest, oldest, cheapest, most active, and most commonly used anti-leprotic drug. Now going forward for the mechanism of action of Dapsone. So you have seen this how the folic acid is synthesized in the mechanism of action of sulfonamides also. Okay, so this mechanism of action of sulfonamides is same as that of the Dapsone. So first step in the synthesis of folic acid is pteridine combined with PABA, that is para-aminobenzoic acid, and with the help of dihydroteroic acid synthase, they form the dihydroteroic acid, and this step is inhibited by Dapsone, also by the sulfonamides. Okay, the next steps already you know, but I am just revising that. The glutamate is then added to the dihydroteroic acid, and it forms the dihydrofolic acid, and dihydrofolic acid is then converted into the tetrahydrofolic acid by the enzyme dihydrofolate reductase. Okay, which drug inhibit this dihydrofolate reductase? Yes, trimethoprim. Okay, so the Dapsone inhibits the dihydroteroic acid synthase, and thus inhibits the folic acid synthesis, especially in the bacteria. Okay, for the folic acid in human beings. So inhibition of PABA incorporation into the folic acid by folate synthase is inhibited by the Dapsone, but the antibacterial action of Dapsone is antagonized by the PABA. So this is a competitive inhibition, as you know, substrate and the drug. So whichever concentration is higher, the one will displace the another. So if we increase the concentration of Dapsone, it will inhibit the dihydroteroic acid synthase. If we increase the concentration of PABA, it will again displace the Dapsone. Okay, so this is a competitive inhibition. At very low concentration, the Dapsone acts as a leprostatic. So it is less acidal, but it is more static drug, inhibiting only the growth of Mycobacterium leprae. Is Dapsone useful in other bacterial infection? Yes, it can be useful like sulfonamides, but the doses of Dapsone which are needed for the treatment of acute pyogenic bacterial infections, they are very much toxic. So that's why it is not useful for other bacterial infections. Okay, so you are clear with the mechanism of action of Dapsone: inhibition of PABA para-aminobenzoic acid incorporation into the folic acid by inhibiting the dihydroteric acid synthase enzyme. Now, there are very high chances of developing the resistance to the dapsone. Okay, so dapsone resistance to the Mycobacterium leprae is first noted in 1964. So almost we can say 60 years before. And because of that, it necessitates the use of multi-drug therapy, that is a MDT. Just like tuberculosis, we are giving drugs in combination and not a single drug. Also in a leprosy, we are giving the drugs in combination, okay, because to prevent the development of resistance like this one developed in the dapsone. Now, two types of resistance are there in the dapsone. One is a primary resistance, and the another is a secondary resistance. So, what is primary resistance? Yes, when the dapsone resistance is present from beginning of the therapy, the bacilli, lepra bacilli, they are inherently resistant to the dapsone. That is a primary resistance. So that will encountered in the untreated patient. That patient has never taken the dapsone before. And how this can happen? Primary resistance, if the infection was transmitted or contacted to a patient from another patient who is already having resistant bacilli. Remember, this is an infectious and contagious disease that it can be transmitted from one person to another. So if the person from which it is transmitted, if that person is having the resistant bacilli, then there are chances of primary resistance. And the another is a secondary resistance, the resistance which develops during the monotherapy. So the bacilli were initially sensitive to dapsone, but in a due course they become resistant. Okay, so now what is the main mechanism of development of resistance to the dapsone is that there is a mutation in the folate synthase enzyme or dihydroteric acid synthase enzyme, and because of the mutation in this folate synthase enzyme, the affinity of dapsone for this enzyme becomes less, and because of that it cannot completely inhibit the folic acid metabolism, and because of which the bacterial growth is not inhibited and they can propagate rapidly, okay, or spread rapidly. So mutation in the folate synthase enzyme is the mechanism how the dapsone develops the resistance to the mycobacterium. Now, other uses. As I already told you that apart from leprosy, it can be tried in other bacterial infections, especially acute one, but the doses are too toxic. So apart from bacteria, is dapsone is active against any other organisms like viruses, protozoa or other thing? Yes, so dapsone is active against certain protozoa as well. Okay, so which are these protozoa? It is mostly the Plasmodium falciparum causing the malaria, and Toxoplasma gondii, which is causing the toxoplasmosis. And the another organism is a Pneumocystis jirovecii. Remember, it was in the fungus group earlier, so I have written there fungus, but now it is not in a fungus group, it is in a protozoa only. Okay, Pneumocystis jirovecii pneumonia. So in a sulfonamide you have seen that there is a one drug pyrimethamine and another is a sulfadoxine, SP, sulfadoxine and pyrimethamine. So this combination, sulfadoxine and pyrimethamine, is active against the three infections. Okay, which are they? Plasmodium falciparum malaria, Toxoplasma gondii infections means toxoplasmosis, and Pneumocystis jirovecii, which is mainly causing the pneumonia in immunocompromised or HIV patient. All these three indications, instead of sulfadoxine, we can combine the dapsone with pyrimethamine. Okay, so dapsone, as we know, chemically similar to the and mechanism of action wise also similar to the sulfadoxine. So instead of sulfadoxine, we can give the dapsone. So dapsone and pyrimethamine combination has three uses: chloroquine resistant Plasmodium falciparum malaria, second toxoplasmosis, and third Pneumocystis jirovecii infection. Okay, apart from this, anti-inflammatory property has also been detected in the dapsone. Now coming to the pharmacokinetics of dapsone. So pharmacokinetics wise, it is very well absorbed by the oral route. So obviously it is given by the oral route of administration. It is concentrated in the skin, muscle, liver and kidney, and especially it is concentrated 10 to 15 times more in lepromatous skin as compared to the normal skin. Okay, so as compared to the normal healthy person, the skin of lepromatous person, obviously this I told you that it is lepra bacilli is mostly affecting the skin, cutaneous, mucous membrane and the nerves. So these bacilli, they harbor in the skin of the patient. That's why we are taking the smear of the skin. Mostly it can cause the ulceration, or it can cause just the hypoaesthetic patches. Means a patch is formed where the sensations become less. That is called as a hypoaesthetic patches. So there may be the hypoaesthetic patches. There may be the infiltration of skin with lepra bacilli, and they may result in the nodule formation. There may be the ulceration over these nodules. Okay, so this can happen. So the lepra bacilli, they have the high affinity for the lepromatous skin. So that is a good thing. The drug should concentrated in the organ where the bacilli are residing. So that is a good thing. Okay. The plasma T half of the dapsone is variable, but mostly it is more than 24 hours. So what is the clinical significance of this? Yes, if the plasma T half is more than 24 hours, mostly the frequency of dosing we can keep only once daily. There is no need to give the twice or thrice daily. So once daily dosing of dapsone is sufficient, and that much concentration of dapsone, that is called as a MIC. The MIC value, that is the minimum inhibitory concentration, as you may already learn in the introductory chapter of chemotherapy. So minimum inhibitory concentration of dapsone, if we are giving as a 100 milligram per day dose, it is a quite high for the inhibiting the growth of this lepra bacilli, and it can be given only once daily. As I already told you, in isoniazid we have seen a short form of the drugs metabolized by acetylation. So what is that short form? SHIP, SHIP. That S stand for the sulfonamides, including the dapsone. So dapsone is acetylated in the liver. So it undergo by metabolism by acetylation. It is eliminated in the bile, and it undergoes the enterohepatic circulation. And because of this, means what happened? From the bile it is secreted into the intestine. From the intestine it again come back into the liver, which is called as the enterohepatic circulation, because of which the action of dapsone becomes prolonged, and elimination takes at least 1 to 2 weeks or even longer. Okay, so this. Coming to the adverse effects of dapsone, generally it is well tolerated at a doses 100 milligram per day or less. Okay, but there are the certain side effects which are very characteristics, out of which a very important is hemolytic anemia. So hemolytic anemia in a patients with a G6PD deficiency enzyme. So this is a pharmacogenetic condition. It is a dose related toxicity, and because of the oxidizing property of dapsone, when it is given to the patient who is already having G6PD deficiency, there are the higher chances of hemolysis or of RBC. Okay, so RBC breakdown can occur, that will obviously result in hemolytic anemia, and the hemoglobin level will become lower. And because of this, the dapsone is contraindicated in a patients with anemia when hemoglobin is less than 7 gram per deciliter. So that becomes a contraindication. Okay, and this is the side effect, hemolytic anemia. So characteristic side effect, hemolytic anemia in patients with G6PD deficiency. The second, gastric intolerance like nausea and anorexia. Anorexia means decrease in appetite. Other side effects are there like methemoglobinemia. So hemoglobin becomes reduced, that's why called as a methemoglobin. So there is an increase in the level of methemoglobin, that is one of the side effect. Paresthesia means tingling, numbness type of the sensation. Then the third is the next is a cutaneous reaction. So because it is getted highly concentrated in the skin, as it is advantageous, but it also causes the disadvantages like allergic rashes. Then fixed drug eruption. Fixed drug eruption means if there is an allergy or a particular site of the skin because of drug. So when you are repeating the dose of the drug, mostly that allergy or that lesion appears on the same site. That is called fixed drug eruption. Okay, this is also the side effect with sulfonamides. Then hypermelanosis, melanin pigmentation is increased in particular area. Phototoxicity, if you have taken a dapsone and go into the sunlight, there are chances of the skin, you can say a sunburn type reaction or erythema of the skin. And rarely exfoliative dermatitis. Among the very rare complications, dapsone can cause hepatitis and agranulocytosis. So you have to monitor the liver function and the this leukocyte count while giving the dapsone therapy. So these are the adverse effects: hemolytic anemia, gastric intolerance, methemoglobinemia, cutaneous reaction, and rarely hepatitis and agranulocytosis. Okay. Then there is a characteristic syndrome with dapsone that is called sulfone syndrome. This reaction develops 4 to 6 weeks after starting the dapsone treatment. Means after 1 to 1.5 months, this reaction develops. So what happens in sulfone syndrome? There is a appearance of fever, malaise, lymph node enlargement, desquamation of skin gets, you can say, ulcerated or the it gets damaged. Then there is a jaundice and there is a anemia. So jaundice because maybe damaging to the liver, anemia we have already seen maybe because of the hemolytic anemia reason, and desquamation. So this type of the symptom generally seen in malnourished patient and has become more frequent after the introduction of multi-drug therapy, MDT. So what is the treatment for this? If this type of the sulfone syndrome occurs after the 4 to 6 weeks, you can say, we have to stop the dapsone and we have to institute the corticosteroid therapy along with supportive measures. So as we know, corticosteroid, they have a anti-inflammatory action and they also have a anti-allergic action. So it is useful in hypersensitivity as well as inflammatory reaction. So we have to institute the corticosteroid, especially the prednisolone type, for this sulfone syndrome. Okay. Then the contraindications of dapsone. So as we first already discussed, patient with severe anemia, when the hemoglobin is less than 7 gram per deciliter, this is the one contraindication. Second, the person if having the G6PD deficiency. So this is depends the person's, if you know that already he is having the G6PD deficiency, then never start the dapsone in such patient. And third, known hypersensitivity to the dapsone. So these are the 3 contraindications to the dapsone. Now coming with the second drug, that is clofazimine. So before going to the clofazimine, just to revise the dapsone, it is chemically related to the sulfonamides. It inhibits the folic acid synthesis by inhibiting the folate synthase or dihydroterroic acid synthase, because of which growth of bacteria will not occur. So it is mostly a static drug. The resistance can develop to the dapsone, primary or secondary, due to the mutation in the folate synthase enzyme. The other uses of dapsone, it can be useful along with pyrimethamine in the treatment of chloroquine resistant Plasmodium falciparum malaria, toxoplasmosis, and the pneumocystis jirovecii pneumonia, while the side effects are hemolytic anemia mainly. Now coming to the second drug, clofazimine. So it is a dye, actually it is a phenazine dye, okay, which have a leprostatic, inhibiting the growth of leprae, not killing them, and anti-inflammatory properties. Okay, so anti-inflammatory properties are additional thing apart from the leprostatic property. Now coming to the mechanism of action of clofazimine, there are 3 mechanisms for the clofazimine. First one is a interference with the template function of the DNA. Okay, so as you know, in the DNA there are 2 strands. So one is a template strand and it can interfere with the function of that template strand of DNA in Mycobacterium leprae. What is the second mechanism? It can alter the membrane structure of Mycobacterium leprae and it can interfere with the transport function. So any nutritional substances which the bacteria requires, they may be interrupted and then the bacterial growth can be inhibited. And third, it can cause the disruption of mitochondrial electron transport chain. Okay, as you know, in our body there is an electron transport chain from which the this energy is generated using the ATP, means in the form of ATP, which is present in mitochondria. Just like that, the mitochondrial electron transport chain is present in bacteria, and it will disrupt that mitochondrial electron transport chain, because of which the energy metabolism of lepra is inhibited. So there are three actions: interference with template function of DNA, alteration of membrane structure and transport function, and third is the disruption of mitochondrial electron transport chain. Now, when we are using the clofazimine alone, the clinical response is slower than the dapsone, and the chances of developing the resistance appears in 1 to 3 years. That's why clofazimine is never used alone in the treatment of leprosy. So neither the dapsone, neither the clofazimine we are going to use in as a alone or single drug. That's why we are giving in the combination. Clofazimine, like dapsone, is orally active drug, almost 40 to 70% absorbed, so given by oral route, and very characteristic that it has a T-half of 70 days. Okay, so very long T-half, almost for the 3 days, so that intermittent therapy is possible with the clofazimine. Okay, no need to give the daily with the intermittent, but there is one capping over this we will see in the treatment of. So dapsone, it is useful as one of the component of multi-drug therapy of leprosy. Apart from dapsone, clofazimine is the second drug which is useful in multi-drug therapy of leprosy. Now, apart from leprosy, because of its anti-inflammatory property, it is valuable in lepra reaction. Okay, so there are two types of lepra reaction which we will see at the end of the lecture. In the last slides, there are type 1 and type 2 type of the lepra reaction, and it is useful in both type of the lepra reaction because of its anti-inflammatory property. Remember, here it is anti-inflammatory property which is useful in lepra reaction, not its interfering with template function of DNA or other actions. Occasionally, clofazimine can be useful as a component of multi-drug therapy for Mycobacterium avium intracellular infection. As we see yesterday in the tuberculosis, Mycobacterium avium intracellular complex infection, where mostly we are preparing the macrolides and rifampin type of the drug, clofazimine can be useful there. Okay, but it is rarely used. Coming to the adverse effects of the clofazimine, generally it is well tolerated, but the adverse effects, if appear, they are limited to the two systems or two organs. One is a skin, second is a GI symptom, gastrointestinal symptoms. So what adverse effect appears in the skin? The characteristic is reddish black discoloration of the skin. Reddish black discoloration of the skin because it is a dye, especially on exposed part, and this is more prominent in the fair skin people. Okay, then the second is a discoloration of hair and body secretion. So these are the two characteristic side effects. I am repeating: reddish black discoloration of the skin and discoloration of hair and body secretion, which can happen with the clofazimine. Okay, next, dryness of skin, itching, acneiform eruptions, phototoxicity. So phototoxicity can happen with dapsone as well as with the clofazimine, and conjunctival pigmentation, which can cure the cosmetic problem. Okay, and the second side effect is the GI symptoms, where it can cause nausea, anorexia, abdominal pain, weight loss, and enteritis, inflammation of intestine, enteritis, with intermittent loose stools. But this happens mostly at the high doses. Then why this GI symptom happens in the early? If the GI symptoms appear early, they are mostly because of the reflection of irritant property of clofazimine. Okay, because of irritative property to the intestinal epithelium, this can happen the GI symptom like nausea, anorexia, or loose stools. So how to stop them? This can subside with dose adjustment and by taking the drug with meals. So we can reduce the dose and we can give the drug with a food or meals. So these early symptoms, if they are appearing, they can stop. But when the GI symptoms appear late in the therapy, after a few months, they are mostly because of the deposition of needle-shaped crystals of clofazimine in the intestinal submucosa. Okay, I'm repeating, because of deposition of needle-shaped crystals of clofazimine in the intestinal submucosa, these late type of the GI symptoms can appear. Okay. Now coming to the contraindication. First contraindication to the clofazimine is early pregnancy. So it is not specified, but early pregnancy you can give the I can give the logic that the first trimester of the pregnancy, and patients who are having a liver or kidney damage. So these two types of the contraindications are there for the clofazimine. Okay. Now coming to the third drug, which is the most important in the treatment of leprosy, is the rifampin or rifampicin. Okay. So where we have seen this drug? Yes, in the tuberculosis, so very important drug. Okay, there also it is the most important drug nowadays. Okay, so it is a tuberculocidal drug and it is also a leprocidal drug. So it is a most potent cidal drug for Mycobacterium leprae. If the MCQ is asked which is the most cidal or most potent drug in the leprosy, and the option are dapsone, clofazimine, rifampin, and ofloxacin or minocycline, you have to choose the option rifampin. So it is the most potent cidal drug for Mycobacterium leprae. It rapidly renders the leprosy patient non-contagious. What is the meaning of this? As we know that the lepra bacilli, they are residing in the skin, and the second thing, they are also residing in the nasal secretions of the patients. Okay, so the transmission of leprosy to another person can happen through these nasal secretions, or it might be transmitted through the skin to skin contact. Okay, so if we have to reduce the transmission from one person to another, we have to reduce the bacillary load among the nasal secretions and in the skin also. So that is done by the rifampicin. It rapidly reduces the bacillary load in the leprosy in the nasal secretions and the other body secretions as well as in the skin, because of which transmission to another person chances gets reduced. Okay, and the second thing, 99.99% of Mycobacterium leprae, they are killed in just 3 to 7 days when we are giving the rifampicin 600 mg per day dose. So this is the same dose which we are giving daily in the tuberculosis. So that can kill the almost 99.99% of bacilli in 3 to 7 days. Okay. So once we start the rifampicin, nasal symptoms in lepromatous leprosy, we will see what is a lepromatous leprosy. There are some types of leprosy in the coming slides. So nasal symptoms in lepromatous leprosy subside within 2 to 3 weeks. Okay, and skin lesions start regressing by 2 months. So earlier we start the rifampicin, that is better for the patients of the leprosy. Okay, little benefit in nerve damage already incurred. So we already discussed that it is affecting the skin, mucous membrane and nerves. So if nerve damage is already happened, as you know, they are not neurons or the nerve cells, they are not regenerated again. So once the damage has already happened, it cannot be reversible, especially the ulnar nerve, median nerve and the sural nerve, which are the, you can say, not a deep one, they are the superficial nerves. They are mostly affected in the leprosy, and that can give rise to the permanent deformities of hand or the foots, like the claw hand or the foot drop like this. So if that is already incurred, it may not be reversible after starting the rifampicin. So not satisfactory if used alone. So rifampicin also we cannot use alone, because some bacilli persist even after the prolonged treatment and resistance develops. So there is one word, persisters. So persisters means the bacilli which remain dormant in spite of giving the drugs, and they remain totally inactive, and they can become active after stopping the treatment, and they may be for the developing the resistance. Okay, so rifampicin has been included in the multi-drug therapy of leprosy, whereby it shortens the duration of treatment and no resistance develops to the combination of a drug. We will discuss, but previously for multi-drug therapy of leprosy, there are the regimens for 5 years, then it is reduced to the 3 years, then 2 years, and now we have come to the 1 year. So why that treatment duration is reduced? Yes, because of these drugs, especially the rifampicin type of the drug. It shortens the duration of, it reduces the chances of development of resistance. Now rifampicin remains effective in leprosy even if given once a month. This is a very good statement, you can say, or important statement. So 600 milligram, a monthly dose, which is useful in multi-drug therapy. It is quite effective, it is practically non-toxic, and the second big advantage is that it does not cause the enzyme induction. As we have already seen in the tuberculosis, rifampicin is an important enzyme inducer, and in tuberculosis we are giving it daily, so that enzyme inducing property is quite high. So here in leprosy, if even we are giving once a month dose of rifampicin, that is as effective, and because of that it does not cause the enzyme induction, so there are no chances of drug interactions with other drugs. Okay, so that is a advantage here. What are the precautions which need to take while giving rifampicin? It should not be used in a patient with hepatic or renal dysfunction. Okay, liver or kidney damage, we should not use the rifampicin. Or next kya hai? It should not be used in lepra reaction. Okay, this erythema nodosum leprosum is nothing but type 2 lepra reaction, and reversal reaction is nothing but type 1 lepra reaction. So it is not useful in both type 1 and type 2 lepra reaction, because because of the bactericidal property of rifampicin, it can release large quantities of mycobacterial antigens by inducing the rapid bacillary killing. What is the meaning of this? When we kill the Mycobacterium leprae, the antigens which are present inside those bacteria, okay, means their endotoxin or exotoxins or other body parts, they can be released in the surrounding medium and they can give rise to the hypersensitivity reactions, and they are the lepra reaction. So mostly the reversal reaction or type 1 lepra reaction occurs because of the delayed hypersensitivity to these mycobacterial antigens. So never give the rifampicin in the patients of type 1 and type 2 lepra reaction. We can start after the reactions. Now coming to the other drugs. So three drugs we have seen: dapsone, clofazimine and rifampicin, out of which I told you that rifampicin is the most potent cidal drug. Okay, 600 milligram monthly dose is sufficient, and the mechanism of action of rifampicin is same as we have seen in the tuberculosis, that is the inhibition of the DNA dependent RNA polymerase. So it is going to inhibit the RNA synthesis, because of which the bacterial proteins will not be formed. So same mechanism of action as there is in the tuberculosis. So these three drugs form the main chunk of the multi-drug therapy. Now the other drugs which can be used in case of the resistance or intolerance to these earlier three drugs. Next drug which can be this type of drug is ethionamide. So this is again an anti-tubercular drug, a second line oral drug, which we have seen it can be useful in, yes, MDR tuberculosis. So anti-tubercular drug having antileprotic activity. So it is poorly tolerated and it can cause the hepatotoxicity in 10% of patient. So with this side effect I already told you that it can cause hepatotoxicity and it can cause the goiter or hypothyroidism also in characteristic side effect. Okay, so it can be used as an alternative to the clofazimine, but there are other antibiotics which have come into the market, which we will see in the coming slides. So they are preferred over the ethionamide. So ethionamide 250 milligram per day may be used only when absolutely necessary. Otherwise we can use the another antibiotics in case of rifampicin or clofazimine or dapsone resistance. Now coming to the next, there is ofloxacin. So it belongs to the fluoroquinolone groups. So we know ofloxacin, pafloxacin, moxifloxacin and sparfloxacin, they are highly active against the Mycobacterium leprae. Ofloxacin, pafloxacin, moxifloxacin and sparfloxacin. But ciprofloxacin has a poor activity, a prototype drug, but it has a poor activity in leprosy. So as a component of MDT, we are mostly using the ofloxacin. Okay. So ofloxacin hastens the bacteriological and clinical response. Hastens means it increases or speeds what? Bacteriological and clinical response. What is bacteriological response? Yes, in the leprosy mostly we take the skin smear of the patient. Okay, and when we are seeing in the microscope, we can have a bacillary index. Okay, there are various index, bacillary index, morphological index. So bacillary index is to denote how much bacillary load is present. So that is from +1 to +6. In the lepromatous leprosy, it is the infectious type, there is a high load from +3 to +6. So what is our main aim? To reduce this bacillary index from +3 to +6 to less positive, that is +1, +2, or even to the 0. So that is the improvement in bacteriological response. And second is clinical response, means improvement in the symptoms like the nasal symptoms or the skin lesions, nodules, ulceration, all they can be improved, or these hypoaesthetic or anesthetic patches. Okay, so there may be the improvement in that. So ofloxacin has done both. In one of the study, the ofloxacin found to be bactericidal to the Mycobacterium leprae, and almost 99.9% of bacilli are killed by 22 daily doses of ofloxacin monotherapy. So it is also bactericidal, but it is less potent as compared to rifampicin. So it can be used in alternative regimens in case rifampicin cannot be used, or to shorten the duration of treatment and reduce the chances of drug resistance. So 3 reasons when the rifampicin is not used. So it can be used in that cases to shorten the duration of treatment and to reduce the resistance. So dose is 400 mg per day. Next, moxifloxacin is the most potent fluoroquinolone against Mycobacterium leprae. So remember, ofloxacin is most commonly used in leprosy, but most potent is moxifloxacin. The same thing is tuberculosis. Moxifloxacin is most potent against Mycobacterium tuberculosis, but leofloxacin is commonly used. So we want to preserve moxifloxacin for the coming generations. That is the thing there. Recently tried in some combination regimens with good clinical and bacteriological results. So this is all about the ofloxacin and moxifloxacin. Now the next group is the minocycline. So it belongs to the tetracycline. As you know, the tetracycline acts by inhibiting the protein synthesis. So why the minocycline is particularly useful in the Mycobacterium leprosy? Because of its high lipophilicity. Okay, what is the lipophilicity? Philic means attraction, for the lipo means for lipid. So it has a high attraction for lipid, means it has a high lipid solubility. And you know, the drug which is having a high lipid solubility, it can cross the skin more efficiently. Okay, because the skin is also having made up of the lipid bilayer, so it can get concentrated in the skin, and this tetracycline can penetrate into the Mycobacterium leprae and is active against them. Antileprotic activity of minocycline, but it is less than rifampicin. The spelling mistake is there in rifampicin. So it is less than rifampicin, yes, but it is more than clarithromycin. So minocycline bactericidal activity is in between the rifampicin and clarithromycin. More than clarithromycin, less than rifampicin. Okay. In one trial, 100 mg daily dose as a monotherapy with minocycline, 8 patients of lepromatous leprosy become negative after 8 weeks. So single therapy with minocycline, 100 mg daily dose, and after 8 weeks all patients are negative, means bacteriological response is there. Okay, so good drug, but only serious complication is the vertigo. Okay, so vertigo can happen in the minocycline as a side effect. So it can be tried in alternative MDT regimens provided there is no response to the rifampicin or ofloxacin. Okay, next and the last drug is the clarithromycin. So this is the macrolide group of antibiotic. As already know, macrolide, there are mainly 4 drugs: erythromycin, roxithromycin, clarithromycin and azithromycin. So clarithromycin and azithromycin, they have a high activity against the Mycobacterium tuberculosis, MAC infection also, and especially clarithromycin has a significant activity against the Mycobacterium leprae. No azithromycin. Okay, it is a less bactericidal than rifampicin. So we have seen it is less bactericidal than rifampicin also. It is less bactericidal than minocycline also. So it is a last drug to be preferred in alternative regimens. Now monotherapy with clarithromycin as 500 mg daily dose, it also can kill 99.9% of bacilli in 8 weeks. So rapid clinical improvement in lepromatous leprosy can occur with clarithromycin, especially when clarithromycin is given in combination with minocycline. Both have a synergistic action. What is meaning of synergistic? Both of them is given in combination. One drug enhances the action of another. So there is a you can say potentiation of the each other action. So it can be included in the alternative MDT regimens. Okay. So 3 drugs we have seen: Ofloxacin, Minocycline, and Clarithromycin. All of them have a bactericidal activity against the Mycobacterium leprae, and they can be useful in alternative regimens provided there is no response to the or resistance to the Rifampin or Clofazimine. Or now coming to the main important thing for the pharmacotherapy of leprosy. Okay, just like we have seen a pharmacotherapy of tuberculosis, there is a one program, RNTCP, Revised National Tuberculosis Control Program. Recently I also come to know that the name of RNTCP changed to the National Tuberculosis Elimination Program. Okay, so just like that, leprosy also we have a national program. In India, there is a National Leprosy Control Program which was launched in 1955, but then the name was changed to the National Leprosy Eradication Program. Totally eradicate the disease from the population. There is some definition which we can come in across in the BSM. So National Leprosy Eradication Program, it has been launched in 1982. Means control program is in 1955, that has been changed to eradication program in 82. So what this eradication program introduced? It introduced this multi-drug therapy for leprosy in 1982, and they have keep a goal of achieving the elimination of leprosy as a public health problem. Okay, elimination of leprosy. So what is mean by elimination? Not eradication, elimination. The elimination means prevalence rate is less than 1 case per 10,000 population. 10,000 लोगों के बीच में एक से कम केस होना चाहिए. That is their goal in elimination. Okay, in December 2005. Though some states still had more than 1 case per 10,000 population, so we are not able to achieve this completely. So WHO data as 2010 shows, unfortunately I don't have recent data, so 65% of all new leprosy cases in the worldwide are from India. So that is a quite challenging things for us as a India. About 65% cases are from the India, so we have to look seriously into the leprosy. Now classification of leprosy, this is the actually a part of medicine, but we can cover in the very short. The Ridley and Jopling, these are those two scientists, you can say, they have divided the leprosy into the 5 types in 1966. Okay, these 5 types, which are they? Remember, listen, okay, listen carefully. Lepromatous leprosy, that is LL. Lepromatous leprosy, LL. Borderline lepromatous, BL. Third is a borderline, that is called BB. Fourth is a borderline tuberculoid, okay, and fifth is a tuberculoid. So there are mainly 2 poles of leprosy as per this classification. One is a lepromatous pole and one is a tuberculoid pole. So there is a chart given below to differentiate between tuberculoid and lepromatous leprosy. Basically, the lepromatous leprosy means these are the highly infectious patients which have a high bacillary load. Means there are the large number of bacilli present in the skin lesions of this patient, where the bacillary index and morphological index both are very high. And tuberculoid leprosy is a quite mild or less severe type of leprosy. Okay, where the bacillary load is less and infection, the patient is mostly non-infectious, means the chances of transmitting to another person are less. So we will see the differences. In tuberculoid leprosy, there is a mostly anesthetic patch. So there is a patch on the skin and it might be hypoaesthetic or anesthetic. Anesthetic means loss of complete sensations over that part of skin. अगर आप वहाँ पे टच करोगे तो सेंसेशन नहीं पता चलेगा, कुछ प्रिक करोगे तो नहीं पता चलेगा. और इट मे बी द हाइपोएस्थेटिक मीन्स reduced sensation, not overall total loss. While in lepromatous leprosy, there is a mostly diffuse skin and mucous membrane infiltration. Okay, the bacilli are infiltrated the skin and mucous membrane, and there may the formation of nodules. So these nodules can deposit forms in the skin. They can form in the mostly in the nose. They can form in the ears. So there may be ear nodule, nose nodule. So because of that, there is a nasal deformity, nasal septum deformity, nasal perforation can occur as a complication. Skin lesions can occur. Okay, ulceration can occur. Digits may get lost of both hands and feet. So these are very infectious and complications can occur. Why this happen? In tuberculosis leprosy, cell mediated immunity is normal. Okay, while in lepromatous leprosy, cell mediated immunity is absent. Okay, so there are one test to distinguish this: lepromin test. Like we have a tuberculin test, here is a lepromin test. So lepromin test in leprosy, it is positive for tuberculosis leprosy, while it is negative for the lepromatous leprosy. Now coming to the biopsy, if we are taking the biopsy of skin lesions, the bacilli are rarely found in biopsy in tuberculosis leprosy, while in multibacillary leprosy there is a skin and mucous membrane regions were teeming with bacilli. So there are a large number of bacilli. Okay. Then tuberculosis leprosy, there is a prolonged remission. Remission means symptom free period, or you can say a cure. So there is a prolonged symptom-free period with periodic exacerbation. Exacerbation means increase in severity. So normally the patient remains symptomatically free, and in between there may be some increase in severity of symptoms. While in lepromatous leprosy, the patient mostly progresses to the anesthesia of distal part, atrophy can happen of the parts, ulceration of the digits, absorption of digits or the other body parts. So this can be happen in lepromatous. Now, for operational purposes, WHO divided the leprosy only into the two types. As per Ridley-Joplin classification, there are 5 types: lepromatous, borderline lepromatous, borderline tuberculosis, and tuberculosis. But for clinically, for giving the drug, we have only 2 types. So this is the main thing which you have to remember. The first one is a paucibacillary leprosy, and second is a multibacillary leprosy. So paucibacillary leprosy, as the name suggests, pauci means less number of bacilli, multi means large number of bacilli. So what is paucibacillary leprosy? Patient has very few bacilli and is non-infectious. Okay, it include the 2 types as per the Ridley-Joplin. TT means tuberculosis and BT means borderline tuberculosis. So these are the paucibacillary, less infectious, less severe, or you can say non-infectious, and very less bacilli present in skin and mucous membrane. Okay, while multibacillary leprosy or MBL, the patient has a large bacillary load, patient is highly infectious, and it includes the 3 types. That is LL, that is a lepromatous leprosy, BL means borderline lepromatous, and BB means borderline. Okay, these 3 types are included in the multibacillary leprosy. So there is another thing which can be there, but this classification is not followed. You can see in the table, paucibacillary means 1 to 5 skin lesions, multibacillary means 6 or more skin lesions. Paucibacillary, no nerve or only 1 nerve involvement, plus or minus 1 to 5 skin lesions. Multibacillary means more than 1 nerve involved, means 2 nerve involved, either ulnar, median, popliteal, sural, all these nerves. Okay. Skin smear is negative at all sites and in the paucibacillary, while it is positive at only any one site in multibacillary, but this is not too much followed. Now coming to the actual important part of this lecture, that is a multi-drug therapy of leprosy. Okay. So why it is necessary? So to deal with the Dapsone resistant strains of Mycobacterium leprae and to shorten the duration of treatment, okay, as well as to eliminate the microbial persister form, means the dormant form which remain inactive. The multi-drug therapy with Rifampin, Dapsone and Clofazimine was introduced by WHO in 1981, and it was adopted by India through the National Leprosy Eradication Program in 1982. So we are giving these 3 drugs: Rifampin, Dapsone and Clofazimine. And now the MDT is the regimen of choice for all cases of leprosy. So every patient of leprosy, we have to give the multi-drug therapy and not a single drug. Okay. What are the advantages? There are 4 advantages, as you can see. First one, it is effective in a cases with primary Dapsone resistance. So even the patient is having primary Dapsone resistance, we can start with multi-drug therapy and it becomes effective, or it is effective. Second, it prevents the emergence of Dapsone resistance. Okay, the chances of developing the resistance to the Dapsone becomes less. Third, it affords quick symptom relief and it renders the MBL cases non-contagious within few days. So symptoms of the patients get improved rapidly, like the skin lesions and the ongoing nerve damage, not already happened but ongoing, and it renders the MBL cases non-contagious so that it cannot transmit the disease to another person, and it reduces the total duration of therapy. As I already told you previously, it was 5 years, then 3 years, then 2 years, and now only we have a 1 year therapy. Okay, 1 year for multibacillary and 6 months for paucibacillary, which we'll see in the next slide. So these are the 4 advantages of multi-drug therapy. So this is the most important slide of this lecture. What is the actual treatment or drugs which are given in the leprosy treatment? So there are 2 types of leprosy, as a multibacillary leprosy where bacillary load is high and infectious, and paucibacillary leprosy where the bacillary load is deficient or bacilli are less. So previously the multibacillary leprosy and paucibacillary leprosy, there are the certain differences. So we have know the 3 drugs, Rifampin, Dapsone and Clofazimine. So in multibacillary leprosy all 3 drugs were given previously, while in paucibacillary leprosy only 2 drugs, Rifampin and Dapsone were given, but not Clofazimine. But in the year 2019 WHO changed these guidelines and now it has make all 3 drugs in both types of leprosy. Okay, clear? So it is very easy now for you people to remember for the students, because there is a lot of confusion previously in the students, but now it is very same in both types of leprosy. Only thing the duration is different. It is 12 months for multibacillary leprosy as the bacillary load is high, and it is 6 months for paucibacillary leprosy as the bacillary load is less. So coming to the first drug, in both multibacillary and paucibacillary, as it is the most potent cidal drug, that is Rifampin. So what is the dose? 600 milligram and only once a month. महीने में सिर्फ एक बार देना है 600 milligram. And what is written? Supervise, means in the presence of doctor or healthcare worker, the patient has to consume that drug, okay, to ensure the compliance. Remember, there are some blister packs of the tablets comes for the leprosy, in which contain all these 3 drugs. So there is a 28-day blister pack which is given to the patient to be consumed at home, while for that 1 day treatment he has to consume in front of the healthcare worker or doctor. So Rifampin has to consume in front of a doctor. The second drug which is important in multi-drug therapy is the Dapsone. So the dose of Dapsone is again same in both types of leprosy, and that is 100 milligram daily. Now this is self-administered. So daily he has to take the drug 100 milligram, not monthly like Rifampin. It is daily 100 milligram, self-administered. It is not supervised. It has to be taken on at a home. Okay. And third drug is the Clofazimine. Now Clofazimine, there is a 2 types of doses. One, you can see a loading type of the dose is a 300 milligram, which is given once a month, and that is supervised. That means in the presence of healthcare worker. While another 50 milligram is the daily dose, which is taken self-administered at the home. Okay. Now the duration is for 12 months in multibacillary leprosy and 6 months for paucibacillary leprosy. So Rifampin 600 milligram once a month, supervised. Dapsone 100 milligram daily, self-administered, and Clofazimine 300 milligram once a month, supervised, and 50 milligram daily, self-administered. Okay, 12 month in multibacillary, 6 month in paucibacillary. So 6 blister packs in paucibacillary leprosy has to be given, 1 for 1 month, so 6 for 6 months, and 12 blister packs in multibacillary leprosy. Remember, this is the most important slide. It can be asked as a short note that give the treatment regimens for multibacillary leprosy and paucibacillary leprosy. So this is the most important slide. You have to mug up this. Okay. Now coming to the children doses in leprosy, they have to be calculated on the basis of milligram per kg. So Rifampin 10 milligram per kg as a once monthly dose in children. Clofazimine, we know there are 2 doses. One is a daily 50 milligram, so it is a 1 milligram per kg on a daily basis. 300 milligram is a adult dose, so 6 milligram per kg once monthly dose. While Dapsone is a 2 milligram per kg daily dose. So these are the child doses on a milligram per kg basis. Now coming to the alternative regimens. So these alternative regimens, there are three types. First is rifampicin is unsuitable because of resistance or intolerance. If there is a resistance or there is a intolerance. So what is the regimen? So first is a clofazimine 50 milligram daily. Okay. Here we are not giving the loading. Here clofazimine 50 milligram daily. Now we will not give the rifampicin here. So we are giving the Ofloxacin 400 milligram daily and Minocycline 100 milligram daily. This is for first 6 months. Clofazimine, Ofloxacin and Minocycline. And then for next 18 months we have only 2 drugs. For first 6 months we have 3 drugs, Clofazimine, Ofloxacin and Minocycline. For next 18 months we have 2 drugs. Clofazimine is compulsory 50 milligram daily. Then out of Ofloxacin and Minocycline only 1 drug with same doses. Okay. So this is a total 24 months treatment if rifampicin is unsuitable. Okay, because of resistance or intolerance. Then second, when clofazimine cannot be given because of unacceptable skin pigmentation or abdominal pain, as we know clofazimine can cause the skin or GI toxicity, then we can give the Dapsone 100 milligram daily and rifampicin 600 milligram once a month as usual. And apart from instead of clofazimine we can give either Ofloxacin 400 milligram daily or Minocycline 100 milligram daily. Okay, दोनों में से कोई एक Ofloxacin या Minocycline की for 24 months. So remember alternative is giving for longer duration. Okay, 24 months. Third alternative regimen is for patient resistant to both rifampicin and Ofloxacin. So here now the patient is highly resistant rifampicin ko bhi aur Ofloxacin. So we can try. We can give the clofazimine along with Minocycline and Clarithromycin. Okay. So we have seen Clarithromycin is also active. So here we can give the Clarithromycin, Minocycline and clofazimine for first 6 months, followed by Clarithromycin or Minocycline. तो क्लैरिथ्रोमाइसिन और मिनोसाइक्लिन में से कोई एक लास्ट के 18 मंथ्स के लिए, पहले 6 मंथ के लिए तीनों, लास्ट 18 मंथ्स के लिए दोनों में से कोई एक प्लस क्लोफाजिमाइन. सो अगेन 24 मंथ्स थेरेपी. नाउ प्रोफाइलैक्सिस ऑफ लेप्रोसी. नो दिस इज नॉट क्वाइट कॉमन बट इट कैन बी गिवन दैट टू प्रिवेंट द लेप्रोसी. In which patients we can give this? For adults and the children who are above 2 years of age, who are in regular contact with leprosy patients. Suppose if in a family there is a leprosy case, or in the some ashram where the leprosy patients are mostly staying, if they, to these people, so they can take. So guidelines recommend the use of single dose of rifampicin for prophylaxis of leprosy. Okay, so remember, for prophylaxis of tuberculosis, isoniazid is a drug of choice, while for prophylaxis of leprosy, rifampicin is a useful or drug of choice, you can say. Now coming to the last parts of the lectures, lepra reaction. So there are 2 types of lepra reaction. So first we will see type 1 lepra reaction or reversal reaction. So what is this? So this is seen in mostly the TT means tuberculoid or BL means borderline lepromatous cases. And what happens? There is a manifestation of delayed hypersensitivity to the Mycobacterium leprae antigen. So you know delayed hypersensitivity is a type 4 type of hypersensitivity, cell-mediated immunity. So because of killing of lepra bacilli, their antigens are released in the medium and there happens a delayed hypersensitivity reaction to these antigens. Okay, because of this what happens? There is the cutaneous ulceration develops. It might be present earlier but they get increase in the number. Cutaneous ulceration, skin ulceration, multiple nerves are involved. Okay, and mostly these are the nerves become swollen, painful and tender. Okay, and this can happen, this type 1 lepra reaction can happen even after the completion of therapy. Okay, so type 1 lepra reaction is a type 4 of hypersensitivity or delayed hypersensitivity to the Mycobacterium leprae, where cutaneous ulceration and nerve involvement occurs. And what is the treatment for this? Yes, this can be asked as a MCQ, or lepra reaction can be asked as a short note, even in the pharmac and in the final year in the medicine also. So it is treated with 2C, that is clofazimine or corticosteroids. So clofazimine, which is an antileprotic drug, because it is a static and not cidal drug, so it is not releasing the mycobacterial antigens like rifampicin, it can be given. And it also have anti-inflammatory activity, we have seen clofazimine, so it can be given in the lepra reaction, and corticosteroid like prednisolone. So these both can be given in the type 1 lepra reaction, which is also called as a reversal reaction. Next is a type 2 lepra reaction, which is also called as a erythema nodosum leprosum, especially when it is a severe form of type 2 lepra reaction. Erythema, development of you can say redness on the skin and the itching, and nodosum means formation of nodules. Already nodules may be there, but they are increase in the size and they are increase in number. Okay, so type 2 lepra reaction occurs in lepromatous leprosy, that is LL. Type 1 occurs in tuberculoid or BL. This occurs in LL. It usually coincides with institution of chemotherapy. Once we start the antileprotic drug, this reaction happens. Okay, and it is also a type of hypersensitivity reaction, but it is a type 3 or Arthus or Jarvis-Herxheimer type of reaction to the release of antigen from the killed bacilli, and it may be mild or it may be severe or life-threatening. So when it is a severe or life-threatening, mostly we call it as a erythema nodosum leprosum, ENL. Okay, what happens here? Lepra reaction is of abrupt onset. Suddenly this lepra reaction happens. Existing lesions enlarge. If there are the existing nodules, they become increase in the size. They can become red, swollen and painful. And apart from that, several new lesions may appear in this type 2 lepra reaction. Okay, apart from that, there is a malaise, there is a fever, and other constitutional symptoms may occur in the type 2 lepra reaction. Okay, now what is the treatment of this lepra reaction, that is a type 2? The temporary discontinuation of dapsone, especially in the severe cases. Okay, stop the dapsone in severe cases. And which are the drugs which are given? First is a clofazimine, 200 mg daily. It is effective in controlling the reaction except the severe one, and probably because of its anti-inflammatory property. So remember, clofazimine can be given in type 1 as well as type 2. Okay, second, for severe reaction like ENL, corticosteroids are given, that is prednisolone, in a dose of 40 to 60 mg per day, which is started immediately, and it is continued till the reaction subsides. And after that, we have to taper the dose gradually over again next 2 to 3 months. As we know, steroids have to taper gradually and not stopped abruptly. Okay, so we have to decrease the dose gradually of prednisolone. So first C clofazimine, second C corticosteroid. Which other drugs like analgesics, antipyretics or antibiotics can be given depending upon the symptom and need. Then the third drug which can be given in type 2 lepra reaction is chloroquine. Yes, it is anti-malarial drug and it can be useful to suppress the type 2 lepra reaction. Apart from that, fourth drug which can be given is thalidomide. So we'll see in the next slide. So there are 3 C's which can be given in the type 2: clofazimine, corticosteroid and chloroquine. While first 2 C are given can be given in type 1, and apart from that, thalidomide. What is thalidomide? Actually, thalidomide is an anti-emetic drug which was withdrawn in you can say 1959 because of its characteristic teratogenic side effect called phocomelia. आप लोगों को पता है, स्पॉट में भी देखा होगा आपने, phocomelia, seal-like limbs, which happened when the thalidomide was given to the pregnant female patient, okay, in a London hospital. So because of that, the drug was withdrawn, but now it has again reintroduced into the market with some another indications and with some another mechanism of action. So apart from that antiemetic and anxiolytic property or sedative property which was present there, it has also have anti-inflammatory and cytokine modulatory property, especially inhibiting the TNF alpha, interleukins and interferon. So it can be used in the erythema nodosum leprosum as an alternative to the prednisolone. So I have written there, thalidomide was introduced in 1958 for morning sickness. Morning sickness means vomiting in pregnancy, which is mostly in the first 3 months, and was found to be highly teratogenic and withdrawn from the market in 1961. But now it is reintroduced for the treatment of ENL or erythema nodosum leprosum, as well as variety of other conditions where the cytokines play an important role. and it is also tried in the multiple myeloma. It is a malignant tumor of the plasma cells of the bone marrow. So what is the dose of thalidomide in ENL? 100 to 300 milligram once daily at time. Because of its sedative property, it should be given at. So that's all for the anti-leprotic drug. So just want to again to revise, the multi-drug therapy of leprosy is a treatment of choice for all patients of leprosy, whether it is multibacillary or paucibacillary. Rifampin is the most effective and most potent cidal drug. The duration, the treatment, rifampin 600 milligram once a month supervised in both. Dapsone 100 milligram daily self-administered. Clofazimine 300 milligram once a month supervised and 50 milligram daily self-administered for 12 months in multibacillary leprosy and for 6 months in the paucibacillary leprosy. Other drugs which can be useful are Ofloxacin, Minocycline and Clarithromycin. And apart from that, type 1 lepra reaction, which is a type 4 hypersensitive reaction where clofazimine or prednisolone corticosteroid can be given, and type 2 lepra reaction or ENL we can give clofazimine, corticosteroid, chloroquine and thalidomide type of the drugs. Thank you. That's end from my side about the anti-leprotic drugs.